Ordinarily, I'd say hello, and you'd say hello back, but I'm an old psych nurse, and I'm an auditory processor, and I've picked up a pattern that you probably have picked up too, and that is when people say thank you, they say thank you back. Thank you. Thank you. Thank you for being here. Thank you for asking me. And there is an alternative, and it's you're welcome. So if I were to say to you, on behalf of the 2018 Planning Advisory Committee from the Academy, thank you for being here, you would say? Yes. Listen for that, will you please? It's my pleasure to introduce our speakers for the first panel today. Dr. William Holman is a professor and chair of the Department of Human Ecology at the State University of New Jersey. He's also a distinguished research fellow at Annenberg Public Policy Center of the University of Pennsylvania. He formerly served as the director of Rutgers Food Policy Institute and as chair of the Risk Communication Advisory Committee of the U.S. Food and Drug Administration. Dr. Diana Mason is Senior Policy Service Professor at the Center for Health Policy and Media Engagement, George Washington University School of Nursing. Dr. Mary Wakefield most recently has been professor at Georgetown University and also a visiting professor at the University of Texas, Austin. And prior to these appointments, in March 2015, Dr. Wakefield was named by President Barack Obama to serve as acting Deputy Secretary of the U.S. Department of Health and Human Services, the second most senior partner position in the department. Please welcome the panelists.
Good morning. A little better than that. Jerry got better for your welcome. Good morning. Good morning. Yeah, I've had little sleep too, so I'm right with you. Well, it's my honor and pleasure to be moderating this morning's plenary. I've also been asked to report on high-level findings from two studies that I and my colleagues have recently published that looked at nurses' representation in health news media. In the 1990s, I was Director of Nursing Education Research at Beth Israel Medical Center, and we held the first Nursing Research Day and had posters of research that nurses were doing, and we positioned them outside of the executive offices and in the space where people had to go through to get their paychecks and where physicians had to go through to see patients in ambulatory care. Well, I can't begin to tell you the number of times that we were stopped and said, I didn't know nurses did research, including from executives and from physicians. And so why do we think policymakers should expect nurses to come in their doors with research and science that can inform policy? So also in the 1990s, and I've got a couple slides here, and if you could help me with my slides. There we go. Except I can't see them. In the 1990s, thank you, the Sigma Theta Tau published the Woodhall study on nurses and the media. The subtitle was Healthcare's Invisible Partner. Now, this was a study that was named after Nancy Woodhall, who was one of the founding editors of USA Today. It was conducted at the University of Rochester. They looked at all health news stories published in September of 1997 in 7 leading national and regional newspapers, 3 news weeklies, Time, Newsweek, and 3 trade publications such as Modern Healthcare. And what they found is that indeed we are largely invisible in this media. In fact, in 1997, nurses were used as sources in only 4% of health news articles in newspapers, 1% in the news weeklies, and in industry publications. In Modern Healthcare, nurses were used as sources 0.6% of the time. So I've been highly interested in what has changed in 20 years. We've had the Institute of Medicine's report in the future of nursing, a lot of visibility for that report, et cetera. And so that's not, okay, different slide. Different layout, it's fine. I and some colleagues conducted 2 studies, one of which was an actual replication of the original Woodhull study. This is the study team, and several of them are from the Berkeley Media Studies group that does these kinds of analyses all the time. It's been published by the Journal of Nursing Scholarship online. It will come out in the December issue. We looked at a random sampling of all health news stories in the same publications that were published in September of 2017. And what did we find? Could you advance? Thank you. In 2017, nurses were cited 2% of the time in newspapers and weeklies, 1% in industry publications. Now, the difference is not statistically significant, so we're not saying things are worse. We're just saying nothing has changed. And you can read the article for much more detail on the analysis. I do want to point out that if you look at when were nurses used as sources, they did use this as sources on scope of practice issues, on nurse practitioners, which you would hope they would. But that's about all they used us for. They never cited us as sources on policy issues. And a lot of the articles on policy were about repeal and replace the Affordable Care Act. And who could better speak to the impact that that could have on patients' lives than nurses? But we were never cited in the stories that were reviewed. So we were interested in why is this happening? So we did a qualitative study, and this is the study team for that has been published in the American Journal of Nursing this month. And there's a lot of rich detail in there. Please read it. It has implications for everyone in this audience. But I don't have time to go into all that. So I want to share with you, we interviewed 10 health journalists and asked them, what were your experiences with using nurses as sources? What were the barriers to using nurses? And what did facilitate your using nurses? So there was an overall theme, and this is it, that biases about women, about nurses, and positions of authority in healthcare among journalists, in newsrooms, and public relations staff of healthcare organizations and universities, that they impede journalists' use of diverse sources in health reporting, particularly use of nurses. So we have some sub-themes. One is that editorial biases exist in the newsroom. They are embedded in policies and processes. So journalists repeatedly told us that if they use a nurse as a source, they have to justify that to their editor. When they use a physician as a source, they do not have to justify that to their editor. Also, you need to know that newsrooms, most newsrooms use the Associated Press style book, which until 2018 said that the only person you can refer to as doctor is an MD. Now that has changed in 2018, and some newsrooms do not know that, so alert them to that. The guidelines also say you do not use RN. So if the CEO is a physician, you will get Jane Smith, MD, CEO of the hospital. You will not get, if it's a nurse, Jane Smith, RN, CEO of the hospital. So there are biases there that we need to address. They also told us they do not understand the full range of what nurses do. They know to come to us to talk about nursing issues. They don't know to come to us to talk about diabetes management, to talk about pain management, et cetera. They don't know to come to us for those things. And they don't understand our education. And we are not doing a very good job of educating them about what we do and what our education, well, we don't even understand our education right. Journalists also said they don't know how to find us. If they need a physician, a specialist, they know the specialty medical organization to go to find a physician. They don't know our organizations. They know the AAN, but they don't think to go to the AAN for somebody in a specialty practice. And they don't have time to track us down. So we have to make it easier for them to find us. Another sub-theme was that when they go to the PR staff at universities that have schools of nursing with expert faculty and researchers, or if they go to the hospital where the largest number of healthcare workers are nurses and they go to the PR staff and ask to interview somebody, they are never offered a nurse. And even when they ask for a nurse, they may not be given a nurse to interview. So we all have work to do in our home shops with educating the PR staff about what nurses do and how they are valuable sources. We know how to talk to the public. And finally, we're not doing ourselves any favors. They told us that when we call nurses, they don't answer our phone calls right away. They'll call me back the next day. I was on deadline for yesterday. We don't know enough to make the call right away and say, let me call you in 10 minutes. I'm busy with something. I'll call you in 10 minutes. I do have something to say about this topic. And then you use that 10 minutes to get your 3 key points together. So we've got to get smarter about how to interact with journalists. But they also said nursing organizations don't come to us with press releases. They don't come to us and reach out to us and say, here's a story. And nursing journals are not doing press releases. They get them from JAMA. They get them from the New England Journal of Medicine, from the Lancet. They do not get them from nursing journals. So we've got a lot of work to do on this ourselves. It's not just the responsibility of journalists to figure out what we do and who we are and how to find us. I want to thank the various organizations that did fund this study. I was quite grateful to be able to do this in pretty quick fashion with a lot of support from a variety of people. But I think it speaks to the importance of making sure that journalists know that nurses are researchers, we are scientists, and it makes a difference when we're trying to get an issue on the public's agenda in front of policymakers. Are we spokespeople about the problem and the solutions? Will they turn to nurses as sources? And so with that, I'm now going to turn this over to Bill Holman. Yep. And he's going to talk about some important work that came out of the National Academy of Medicine about communicating science. Bill.
Thanks very much. You're supposed to say you're welcome.
You're welcome.
So I'm Bill Holman. I'm professor and chair of the Department of Human Ecology at Rutgers, the State University of New Jersey. My dean will be very happy that I just said that. And I was pleased to serve on the Committee on the Science of Science Communication at the National Academies. We were part of a consensus panel that published a very important report called Communicating Science Effectively, a Research Agenda. This is available for free download from the National Academy Press, which is nap.edu. It's been downloaded nearly 30,000 times since it was published in January of 2017. It's 150 pages. They're quick, I promise. And I've been asked to summarize those 150 pages in approximately 10 minutes. So buckle up. So we were asked to put together this report for obvious reasons. Communicating about science is so important, not just to health issues, but really to every issue. Science impinges on pretty much every issue that we are dealing with right now. And science especially has something to say about many of the most controversial issues that we're dealing with in society. The charge to the committee was to identify what we already know about how to communicate about science effectively, and then to create a research agenda considering what additional research might be useful to help us more effective, and particularly in the case when the issues are contentious. The chair of the committee was Alan Leshner. Dietram Scheufele, my colleague from the University of Wisconsin-Madison, was vice chair. I'm an experimental psychologist by training. I was included because I do work on risk perception. Other colleagues have expertise in public health issues, in a whole range of issues. It was one of the more interesting committees that I've ever served on. So Alan Leshner, many of you know Alan. Alan wrote on page 7 of the introduction what I think is perhaps the understatement of the century, which is communicating about science effectively with public audiences turns out to be more difficult than it might first appear. Alan's a bright guy. And it is. It is. We have a couple of key points to get across. One is, and these are fairly obvious, people communicate about science for diverse reasons. And I'll talk about that in just a second. It's also important for us to understand that there is no single audience for science information. Communicating with policymakers requires different strategies than communicating with the public in general, which requires different strategies than communicating with individual patients, with colleagues, and so forth. So there's no single audience for science communication, and we have to change our strategies to respond. Societal context surrounding different scientific issues can also vary considerably. For example, the context around communicating about vaccines is different from communicating about climate change, which is different than talking about food insecurity. So the key thing is that our communication approaches need to change in response to those particular contexts. There is no single best way to do this. Our strategies need to fit the particular context. So one of the things that we talk about in the report is that indeed there are different goals for communicating about science. And I do a lot of work around helping experts do science communication, learn how to communicate about science more effectively. And one of the things that I begin with is be clear about your own goals. And I know that that sounds ridiculous. It's the basics of communication, but it's the single largest mistake I see in effective science communication, right? So why are we doing this? What are we really trying to accomplish? So are we simply trying to share the findings of a study? Or perhaps the excitement that we have in doing scientific research. And I mean, for me, there's nothing better than getting to the end of a scientific study and thinking, I now know something that nobody else knows, and I can't wait to share this. So that's one goal. Another is to increase the appreciation for science, and perhaps the funding for science and along the way, to increase knowledge and understanding of the science related to a specific issue. So educating people. Then there's persuasion, influencing people's opinions, behavior, and policy preferences. And finally, science communication is often at stake when we're engaging with diverse groups so that their perspectives can be considered in seeking solutions to particular societal problems. Now, of those 5 goals, I want to emphasize the difference between 2. So there is a difference between providing the information to people and letting them make up their own minds and persuading people. And one of the big problems that we face as science communicators is thinking that providing information is persuasive. It is not. You know this intuitively. The science suggests that the correlation between knowing what to do and actually doing it is about 0.2. Right? And any of you that have children know that. All right. So education is not persuasion. Knowing what to do is necessary but not sufficient to persuade people. So we need to, one of the big emphases in the report is that as science communicators, as health communicators, we need to go beyond what we refer to as the deficit model. Right? I can't tell you the number of times I get a chance to speak to many audiences around lots of different scientific topics. And typically somebody in the audience who looks a lot like me gets up and says, if people just understood more about the science of this topic, everything would be fine. And that just does not work. Sorry. Communicating facts is important. But we know from the science of science communication, from the psychology of risk perception and risk communication, that people engage in motivated reasoning. Often their positions about controversial issues are about who they identify with, who they think they are. It's not about the scientific facts. And in fact, basic human nature creates us or allows us to twist information in ways that fit with what we already believe. We know from the basic psychology that we will look for information that confirms what we already believe and who we think we are. We will reject information that's inconsistent with our identities, with what we believe, with the decisions we've already made. And when we cannot do that, we will twist that information in ways to make it consistent. We are highly resistant to changing our minds. All right? We also know that effective risk communication, science communication, begins with understanding and connecting with shared values and concerns. There is, in the era of social media, a huge amount of virally disseminated nonsense. And dealing with that virally disseminated nonsense isn't just a matter of correcting the facts. It's trying to figure out what the motivation is, what the value is, what the concern is behind that nonsense, and addressing that specific value, that specific concern, not simply replacing false facts with correct facts. We also have a diversity of communicators and audiences, scientists, media, advocacy organizations that we have to communicate with and are themselves communicating with various audiences. So in addition to emphasizing the fact that we need to get beyond this educational deficit model where simply providing more facts is going to correct the situation, one of the other quotes I really want to emphasize from the report is, the committee believes that while scientists have a duty to speak about their work, they have an equal duty to listen. We have a responsibility to listen and to engage. And connecting with what we just heard about the paucity of nurses in the media, it is our responsibility, it is our duty to engage. Engage with audiences, engage with virally disseminated nonsense. We need to speak up. And in doing that, we need to learn the science of science communication. The problem is that very few of us have any formal training in the science of science communication. Most of us rely on our intuitions. And in this case, as with everything else, intuitions, even informed by experience, isn't always right. So we need to use scientific principles to more effectively communicate about science. We do know a great deal about the science of science communication. We know, for example, how people take in and filter information. And we know about the nature of science-related controversies. We know about people's numeracy and innumeracy and how to communicate about probabilities and frequencies. We know about people's mental models and schemas. We know how they make decisions based on simple heuristics, on emotions. We know about motivated reasoning. We know about cognitive dissonance. We know about social influences on the decisions that people make. We know how to frame issues so that people can actually see those issues from a different perspective. We know about the importance of trust and credibility, how to earn it, how to lose it. We know about beliefs, values, and interests. We know how to tailor messages, how to communicate uncertainty. We know how to debunk misinformation. We know how to do better public engagement, and we know how to work with opinion leaders. We know a great deal about the science of science communication. We also know how science is covered in mainstream news and how to influence it. We know how journalistic decisions are made. We know how journalism affects public perceptions. And we know increasingly about how social media is changing science communication. We know about preference-based effects. We know who is connected to whom in social media. We know about contextualized news. We know about widening knowledge gaps due to social media. So we know a lot about the science of science communication that we are eager to share with you and that we want your students, our students, to learn so that they can be more effective science communicators. However, we don't know everything, which is where the research agenda comes in. We need to strengthen the research enterprise around the science of science communication. We know that science communication is a complex system of many interrelated parts. The content and formation of information, the diversity of organizations, the channels of communication, and so forth. We need to understand better how these various elements interact. We also need randomized control studies to figure out how to better communicate. We need research that stimulates real-world information environments. We need analyses of large data sets. We need aggregation and sharing of experiences across disciplines. Finally, we need support for and engagement in researcher-practitioner partnerships. We need the science of science communication to influence practitioners, and we need practitioners to come to the researchers and say, we have this experience, we need to ground truth this. Help us figure out how to do this better. We need to recruit more researchers from a variety of disciplines, and we need to develop policy mechanisms for rapid review and funding of science communication to respond to new and emerging issues. One of the things that I'm very proud of doing right now is editing a special issue of the Journal of Risk Analysis on the emergence of Zika. And how do we communicate better about Zika? We need the ability to respond to issues like that immediately, not a year from now. Mm-hmm. So, bottom line, there is a science of science communication. We know a lot. We're willing to share. We need our students to learn how to do this. So thank you very much.
Thank you.
Mm-hmm. Right.
Thank you. And it's a good reminder that we are in an information age, aren't we? All overloaded with information, and so your remarks are very helpful. I also want to point out that Bill just came back last night from Kazakhstan.
Kazakhstan.
Yes. And we appreciate your effort to come back last night after a very long trip and be here with us this morning. Thank you. So it's now my pleasure to have a conversation with a woman sitting next to me. So Dr. Mary Wakefield is, if those of you who know her, it's always fascinating to have a conversation with Mary. And so that's what I get to do right now, although she's trying to defy me with her computer. So, Mary, you have served as Chief of Staff to 2 U.S. senators. You've been the administrator of HRSA, the Health Resources and Service Administration. You've been acting deputy director of the Department
Secretary.
Oh, secretary, sorry.
That's all right.
It's not all right. Acting Deputy Secretary of the Department of Health and Human Services. So, given what Bill just said, and discussing communication science, I think it'd be quite helpful to hear what you've learned from sitting in these various positions about communicating science to policymakers. So could you say, from your perspective as a policy person sitting in these positions, what worked best for communicating science to policymakers to influence policy?
Yeah, it's such a great question, and thanks for the invitation to be up here with you. And I don't ever participate with Diana Mason on anything except that I'm armed and dangerous with my own information, which offended her quite a bit, could I say, that I would actually have information in front of me. And she just alluded to that. But just a few comments, and I want to back up a little bit from your question. I think that based on Diana's information shared from the study and Bill's information shared, a real call to action from my vantage point to this community. Both of these are bookends on a call to action that suggests that there is so much more that nurses and nursing leaders need to be doing to engage in this environment. That it's simply not enough to publish research in nursing literature and call it good, or publish research in some other discipline's literature and call it good. That is hardly even the beginning if what we want to do is to inform health policy. Some people will question, I think, whether or not that's really all nurses' roles, that is to engage in the public policy, in the health-related public policy arena. And I would say it absolutely is, to the extent that our profession is all about strengthening and sustaining health status, for the public, or of the public, individuals and families and communities. If that is our work, and that it is our work, then we do that, of course, as educators and researchers and clinicians, where we impact 40 students or 4 patients on a shift, et cetera. But it is also our work to impact health status of 20 million Americans. 200 million Americans, and so on. If there is a threat, either a policy that can threaten their health status, or there is a public policy that can improve and strengthen their health status, then that's where nursing plays too. It isn't an either or for me, it's both. Might be a little difference in terms of how much time a person spends in either of those arenas, but policy for me transcends the populations for whom we care, and our research should feed it. Our research should inform it. But it's not just our research that informs a health policy or should inform it. Nurses have, I think, a unique position in healthcare in many ways, and I think the public recognizes that. Nurses have expertise, of course. We have knowledge, of course. Nurses are leaders in healthcare, of course. But nurses are also, in addition to all of that, as important as that is, as we know, nurses are also highly respected. Nurses are trusted. And at this point in time, where we've got questions being flagged about evidence, where we have an erosion of the public's trust in facts, this is the time, I would say, this is the time when nurses need to be thinking about how they leverage into that gap. That, from my vantage point, is actually widening. It's not getting better. So this isn't an option for us as a profession, because I would say to you, if not nursing, then who? If not us, who's doing that? Who's bridging information into health policy from a trusted source? We don't have Walter Cronkite anymore brokering information. Tom Brokaw is not out there quite as much as he used to be. So my point is, our research is important, and lifting it up and sharing it with policymakers is important. We can talk more about how to do that. But it's not just stopping at the edge of nursing's research, because there's a lot of great policy analysis and research done by others, by either other nurses, other social scientists, other healthcare providers. It's lifting that information up too. I can broker that information as a trusted source to the American public. I can broker others' research as a trusted source to public policymakers. And I would suggest that's what all of us should be focused on doing, not just our research, but others as well. One other point on this point, and that is that as we work with our own research or the research and scholarship of our students and of our colleagues, when we start with that initial research question, all the way through to thinking about the implications of that research, we always have as part of our consideration on the very front end of the frame on that research question, what are the potential implications for health policy? Always, always, always that my vantage point should be part of the dialogue with the nursing student with whom we're working or with our own research team. Let's not just think about the impact on the health of this population, the impact on the health of health systems, the impact on healthcare reimbursement. Let's think about, more broadly, the impact of policy. So part of this is nesting our work in that broader public policy discussion, right from the very beginning of conducting our research. You're wanting to interrupt me, go ahead.
I do want to interrupt.
You'd like me to take a breath.
I want you to take a breath because I want to ask you then, what is your opinion then of tenure and promotion criteria, particularly at the assistant professor and associate professor level, that give no credit for what you are doing to influence policy?
Yeah. Well, so.
You can comment on that too.
Well, why don't you?
You're trying to get off
like
the
that?
hook.
No, I'll comment on this. But he's an academic day in, day out.
Yes.
As he looked up from the wheels of the bus. As a department chair, and as someone who does risk communication, science communication, this is a really, really important issue. And one of the things that we know, so yes, in the current system, it's often difficult to get the credit that's deserved for doing communication, for influencing policy. But more enlightened deans, more enlightened presidents are increasingly focusing on impacts. It's not how much you publish, it's about the impacts of your work and demonstrating those impacts. And if you can demonstrate that you are changing the public debate, there is nothing better than that. It is much easier for me as a chair to write that letter for the promotions committee to saying this person is making a difference If I've got some evidence like that, absolutely. I will also say that there is good evidence, good scientific evidence, that young professionals, young scientists, young health professionals who do engage in social media, for example, have better chances at tenure. Their research gets picked up more often. There is increased credibility. It's easier to find you if you are a journalist. And so there are some real advantages, even if you're not getting official credit for what it is that you're doing.
So I hope the academics in the audience have just heard. Yes.
And I would just add that I can barely add anything to this, but I would say one thing. I think that's part of it's incumbent upon leaders in academic environments to help support this body of work too, to value it, to lift it up, to raise it up, and to point to it in terms of its importance. That's just critical, that leaders provide air cover for their young, next generation healthcare professionals, nursing professionals who are coming up through the line, and that individual is not out there on their own, but that there's air cover from the department chair, from the dean, et cetera. That is the business that we should be about inside academic institutions. And you can code this as research, but you can also code it as community service.
Yes.
It is that too. It is engaging with the media. It is engaging with public policymakers. That's community service. I can be on the board of Red Cross, or I can also be an opinion leader in my local community at my state level and the federal level as well. So it's really important that we value this and we find ways to protect and encourage people who are engaging it.
So I interrupted you, and I apologize, but I don't. Were there any other key points that
you're welcome?
You're welcome.
You're welcome.
Were there any other key points you wanted to make about, from your perspective of communicating science to policymakers?
Yeah, these are some general, or a more general comment or two in terms of communicating to policymakers. One, and this point has already been made now by a couple of speakers over the last couple of days, but I actually had it too, so I think it's worth reinforcing. It's important to know what a policymaker's position is. That's a given. But equally important, you heard it yesterday and you heard it again this morning, it's important for you, to the extent you can know it, to the extent it is knowable, that you know why they hold the position they hold. Because that's the context for your work. It's not just what they say or what they think or what they're saying about how they're going to vote on an issue or what the proposed regulation is that's coming out from the U.S. Department of Health and Human Services. It is also the why. What stands behind it? Bill Hoagland, a wonderful Republican staffer, he and I overlapped, I think, actually, when I was on the Hill a long time ago. Yeah, decades ago. He made the point about Senator Domenici, a personal drive to impact access to mental health services because of one of his children's own mental health challenges. When I worked in the Obama administration, there was credit in the bank for me. Do you know why? On those few occasions when I actually had the opportunity to talk to the president, there was credit in the bank already because he had had a daughter who was a young infant that was seriously ill. And I mean seriously ill. And to whom did he credit so much of the getting better, the support, the psychological, mental health support, the diminishing of the stress for the family? To whom did he credit that? He credited it to nurses. So that was in the bank for me when in my conversations with him about issues, because it had that personal experience. So part of this is to know what. In other cases, it's political ideology. It's, well, because I've said on the campaign trail that I'm going to do X, and so I'm going to do X. So I can't back off of that, even if you put data in front of me. It's important to figure out what's the why behind the what. So equally important that in terms of people's interactions with policymakers. And also, highly technical material is not helpful. Bill, you actually made this point. It is not helpful when we're communicating with audiences, whether that's the media, the public, or policymakers. And by the way, if I want to influence policy, you know where I spend a lot of my time? Talking to the media. That's what I do. That's what I've been doing for about the last 3 months. A lot of my conversations have been with the media about issues around public policy and the protection of people with pre-existing conditions, access to health insurance coverage. I've been on a tear on that front, and a lot of it's informing the media in order to come back around and inform the public and inform public policymakers. Trust me, I know the email addresses of people who work on Capitol Hill. That's not always the best routing to go with your information. So many times, surely it is, but not always. So we have to think about who are the stakeholders that we need to reach out to, and how are we packaging that information for their consumption. There's probably a reason why when you fly on airplanes these days, you hear the pilots saying, and keep your seatbelt buckled up in case we encounter any rough air. Used to be turbulence. Anybody else notice that? We always used to hear, in case we encounter any turbulence. You don't hear that anymore. You hear rough air. Probably for good reason. Lots of people, lots of different backgrounds. So my point is simple attention brought to the language that you use is really important. I'll just end with this really quick anecdote. My first position on Capitol Hill, working as a health legislative assistant first and then as a chief of staff to a U.S. senator from North Dakota. I was a fresh-faced, roughly 2-year-old faculty member. Was tenured as an associate professor, chairing a department back at the University of North Dakota, had this opportunity to come out and work in Washington, took it, hardly ever having spent any time in Washington, D.C., but took it, and there I was doing my work, writing narratives for the senator, drafts of letters on healthcare issues that he then would review, buff, and then send out, of course, under his name. One day he stopped by my desk, and this is what he said. "So Mary, so glad you're here. You've been here for about a month. And let me say something to you. You're writing like a university professor." Gosh, I wore that like a badge of honor. I beamed. I was so proud of myself. Yes, he recognizes my PhD and master's and the fact that I can put a subject and a verb together with multisyllabic words. Gosh, I'm so excited. So I looked at him foolishly, I realized in retrospect, and said, yes, yes. And he leaned over, nice guy, had his own JD, so well educated in his own right. He leaned over and he said, "So you're writing like a university professor? Stop it." All right then, stopped it. And I've never gone back. I've never gone back. And that simple, straightforward language for all the audiences that I deal with, it works just fine. But the point is, it's really modifying your language depending on the audience to whom you speak. It has to be understandable in order to communicate effectively.
So let's say that I and my partners have been working with you on a policy that is evidence-based, addressing political realities. You know, it's not perfect, but it's good. And I'm really happy about this. And I'm expecting you to be communicating this, and I'm waiting, and I'm waiting, and I'm waiting, and nothing has come out. And I'm starting to get really upset with you, Mary.
You wouldn't be the first one. So have at it. Take a number.
So, what are the challenges that you experienced in communicating policy to public from those positions you've held? And how can I help you to communicate this new policy to the public?
Yeah, such a good point. First of all, you have to be known. You meaning nursing, not even necessarily you as an individual, but the nursing community needs to be known. And some of your research that you shared with us sort of tells us we've got some more work to do on that front. We can do it, bright people in this room and elsewhere, but it absolutely needs to be done. So that's sort of the first thing, letting people know about the expertise that we have. It's important in health, in the public policy arena, that the nursing profession's value add is recognized. You mentioned Zika earlier, Bill. I remember because I was working as when Zika was becoming an emerging, extremely disconcerting crisis and issue. We were learning in real time inside HHS the nature of this problem. So this was not pulling the playbook out and figuring out how to handle something that was well known already. This was in real time, moving quickly, and then trying to communicate as quickly and as effectively as possible to keep the misinformation as much as possible out of the audience and out of the public domain. So from where I sat as the acting deputy secretary, who did I reach out to almost immediately as we were getting data to communicate to the public to help manage expectations around what this disease was and wasn't and its implications? Because I knew them, I reached out to nurses. I reached out to nursing organizations, got CDC on the phone, got Emergency Nurses Association. Why ENA? Why? Because some of these people are concerned with, we're going to be appearing in emergency rooms. And in fact, the one case, as you'll recall, in Texas, an individual died from the disease, did appear in an emergency room. So why emergency nurses? That's the reason why, and I knew it. Public health nurses, I knew it. American Nurses Association, I knew it. I knew to call on those nursing organizations because they're trusted, they're experts, they care. And they'd work with us. So got them all on the phone on different occasions with their leadership and asked them to help message information to nurses in the field who could then help message that information to the audiences with whom they worked. But first, policymakers have to know to reach out to nurses. And you cannot assume that that's always the case. There isn't a nurse sitting in the positions that I held in the Obama administration, not in either position right now. It doesn't mean that an administration doesn't know about nurses, but you sure can't assume it. And so that sort of extra effort, that extra requirement for us to sort of step forward and remind them of who we are and how we can help. Hey, we're from the nursing profession. We are here to help. Because we are here to help. So really important, I think, that policymakers know and recognize the value add. The other thing is remember, and try not to take it personally, administrations come in with priorities, and there are crises that emerge along the way. Your research might be some of the best research ever done on a particular topic, but it is against the backdrop of an environment that could not be more dynamic. State government, that's true. They're managing all sorts of issues. Federal level, that's true. Even local county and city officials, that's true. So you're trying to introduce your work, or somebody else's work, as I said, your policy analysis, your research findings into a highly dynamic environment. And that means that they may not have any concerns at all about the quality or caliber of your research. They may have concerns about the agenda that they've either already established in the public domain or that is being foisted on them because of other things that are happening in the environment. So don't take that personally, but continue to work those issues, staying in touch with policymakers, reminding them that you're there of the research. And I would say one more thing, bring along your friends. Bring along your friends. Make your issues and your data about more than just you as a researcher, about more than just the nursing profession as the advocate and standing behind that research. When I say bring along your friends, bring along your national nursing organizations, or if you're operating at a state, bring along your state nursing organizations, and bring along other groups. If it's about children's health, your new research, March of Dimes. Have you picked up the phone and called them and said, this is my new research? We just sign on to the next email that I'm sending to my policymakers. AARP, if what I'm talking about is care of patients with Alzheimer's. Can I call my local state affiliate? Can I call the national organization? It's really important to bring a concerted effort, and that concerted effort is with other organizations that have a stake in your research findings. They're not hard to find.
And maybe even consumer organizations. One of the questions we have had for both of you had to do with is it helpful to bring in patients and families who have participated in research or organizations that represent them?
Well, and I'll cut in front of you. So anyway.
Please do.
What choice do you have? Thank you.
You're welcome.
I'll be quick. The point that I was going to make is that, and it's been made also before, you know, we can talk about a lot of data. We can talk about how the American Health Care Act would have, according to the Congressional Budget Office estimates, would have rolled back health insurance coverage for 20 million people in the United States had that bill passed. We can talk about data. I can talk about 20 million people. I can talk about 49,000 people in my home state of North Dakota being adversely impacted by a Texas lawsuit, a lawsuit that's paying out in Texas right now related to pre-existing conditions. But there's nothing quite like putting a face, a family, a community on the front end of that communication. We don't do that in research. Our research sort of tends to be the research. I'd suggest that nurse researchers need to step back and think about even how we're presenting that research in our research journals. Where's the anecdote? What's wrong with putting an anecdote in the mix? And by the way, of course, as you know, we don't lead with our methodology, the statistical analysis when we're putting policy briefs in front of policymakers. We don't lead with that information. We reformat, and I'd say, as you're thinking about reformatting, maybe we need to do a little bit more reformatting formatting, of finding ways to infuse personal experiences. There's nothing like that anecdote that can stay with individuals. The last point that I would make on this as a nurse is, throughout my 8.5 years working on Capitol Hill and my 8 years working in the Obama administration at HHS, there was not one policy decision or program decision that I made that I didn't start. The first question in my mind was always, what's the impact of this on patients? What's the impact of this on people, on families, on communities? I always started there. That is in nursing's DNA. It's in our DNA. I didn't start with, is this good for nursing? Is this good for a local hospital? I started with, what difference will this make to the patients, the people that benefit from the Ryan White Care Act, if we make this change? What difference will it make if we bump up the funding level for telemedicine to rural communities? What difference will that make, and how will we know? So that's where we start these conversations and our thinking, I think, always. And again, it's part of the reason why nursing's opinions and remarks are so often appreciated by the public, because they trust us to act in their interests. And I think we can never let go of that. That always has to be our motivation. Not ideology, not budget, not any, there's just nothing else in terms of starting the conversation. It's about what difference will it make to the patient. We own that as a profession.
And Mary, could you just very quickly talk about, in your positions, and your position as Deputy Secretary of Health and Human Services, the kinds of clearance you had to go through to communicate about a policy to the public, any communication you did with the public?
Sure. Start with this. There's a reason why, for example, the budget for the United States government is labeled as the president's budget, because it's the president's budget. So we lift, we do all the background work, for example, on budgets each year at the local Health Resources and Services Administration level, across each one of those 90 programs that are within that part of that operating division of HHS. We look at the entire overall proposed budget for HHS. The secretary speaks to the budget. The leaders of the different operating divisions, from CDC to HRSA to NIH, also talk about their particular budgets in press conferences, their component parts. But at the end of the day, it is the president's budget. So that work doesn't begin and end with nursing workforce funding within the Bureau of Health Professions at HRSA. That's not where that work ends. It flows all the way through HHS over to the Office of Management and Budget, which, as you know, OMB operates is an arm of the White House. So it is the president's budget. So when you think, well, why didn't Mary Wakefield do X or Y, or she could have done more? Well, because Mary Wakefield isn't the president, and isn't sitting over at OMB.
You could be.
Yeah, right. Yeah, right. Thank you. But no. So it is a process inside the organization. The other point is regulations. As when your nursing organizations call on you, you get those fast emails saying, please respond, please contact your congresswoman or congressman. To me, that's one of the most important things that we can ever do during the course of our day. When we are being asked to respond on an issue, to weigh in on an issue, they couldn't make it any easier for us from my vantage point. So all by way of saying that we need to weigh in, but there are processes across the board. I use budget as an example, but there are processes across the board. There is no one individual that can, with some exceptions, that can solely weigh in on big ticket items. It doesn't belong to just one individual. There's a lot of background work. And on the regulatory piece, there are parts of that process that basically must be pulled out of the public discourse so that the work stops in terms of public engagement and can focus explicitly on the work inside the agency. So there are even parts that are built in so that the agency can do its work separate and apart, and then tee up ultimately those proposed regulations and so on. So it's about knowing where in the process to engage. Associations help you to know that. Professional organizations help us to know that. But it isn't. These are not simple processes, and I don't speak just for me as a federal employee when I was one. I'm speaking for the federal government. I'm speaking for the federal government, no matter who I'm talking to. It's not just me and my opinion. So that's a little bit more complicated.
Great. So we have a couple questions that deal with the issue of alternative facts. And I think all of us hope that our federal government including the White House, the CDC, HHS, whatever agency, is going to share evidence-based information. But recently there's been concern about the removal of evidence-based information from some government websites and putting up information that aligns more with ideology than with science. There have some examples around climate change, reproductive health, et cetera. So my question to both of you is how do we respond to this? How do I as an individual and how do nursing organizations respond to this in the climate that we're in where science doesn't seem to matter? Bill, do you want to start first?
Sure. I think that first we need to make a distinction among the various varieties of false information here. So there is misinformation, there is false information, and the motivation for the dissemination of that different kind of information is different. So there are some honest mistakes that are out there. It's a misinterpretation of the evidence that's out there, where it's a shaded interpretation that's supportive of a particular position. That's different than an outright lie. And one of the things I think we need to be able to do is to call out an outright lie.
Yes, yes. Thank you. So does the Nursing Association, does the Academy go out with a press release saying, sorry, our president just lied?
So that would be the last press release. No, so we need to, again, look at what's behind this? What's behind this misinformation? What are the values that are being expressed by this misinformation? Is there a way for us to address those particular values with the information that is in fact correct, or new information that reframes what's being talked about in ways that actually make sense?
Great, thank you. Mary.
I would just say, I think it is nursing's responsibility that when nurses see information that supports policies that can harm patients, that can harm the health of the public, there should be no daylight between that data or that misinformation and our response. There should be no daylight. If it can adversely impact the health of the public, it's our responsibility. And I think we all own that responsibility. It means that sometimes we've got to sort of get out of our comfort zone because maybe, gosh, our 3 priorities for my nursing organization are really A, B, and C. But there's a discussion or an elevating of false facts, of misinformation that seems quite deliberate to accomplish a certain end, and that end could adversely impact the health of people. That's all as a nurse I need to know. That's all I need to know. So my organization may have 2 or 3 priorities, but if whatever this set of facts are, misinformation, or policy direction will impact adversely the health of the public, then I have a stake in that as a nurse. My organization has a stake in that as a nurse. When I've seen that happen, I've picked up the phone and I've called nursing organizations. I've talked with the head of ANA. I've talked with the head of NSNA. And thank you that when I did, they were already stepping up in some fronts. They stepped up further to advance additional information. And it's reinforcing, and then it's also thanking nursing organizations who are willing to do that, who step out of their day job, the 3 issues that they've got in front of them. When you see some static in the environment, that at the end of the day, if it gains ground, it will be problematic. So I think there should be, as I said, no daylight between those kinds of challenges and nursing's thinking about whether or not to respond. We owe it to the health of the public to respond, as I said, even if it's outside of our usual book of business. And I think that the evidence-based information, when it comes from nurses, carries some particular weight. We want to be correct every time we speak, every time we speak. That means doing the due diligence. And we want to partner where we can. That provides us with air cover, too. I can't tell you how many times I've done that. Pulling in American Cancer Society, referencing the American Hospital Association, referencing the American Association of Medical Colleges, if they've taken a position, referencing nursing organizations. That's part of my dialogue when I'm talking about the information or a policy piece, and other groups have come in and weighed in on that policy, on that misinformation, et cetera. So it doesn't just have to be about me or about nursing. As a matter of fact, when we can, we should make it bigger than just nursing, because that is a broader draw, I think, for the public, when they can see themselves in the organizations that have come together to advance a position.
So I think you have heard a challenge that is issued to everyone in this audience about stepping up on the communication platform. At the Institute for Nursing Leadership Workshop the other day, somebody reported on how somebody spent $1 million to look at who was the best communicator around health issues, and they determined that it was nurses between the ages of 50 and 60. So I don't know why we needed $1 million study to determine that, but I think it says that we are perceived in this way, and we need to step up to inform policy with the evidence and in smart ways. I want to thank Bill Hallman and Mary Wakefield for joining us.
You're welcome.
Thank you. Yeah. You're welcome. Good. And now Karen Cox. I'm turning it over to Karen Cox. Excellent. Excellent.